So good evening, everybody. Welcome to Adoption UK. Thank you very much for joining us. This is the start of Adoption UK and FASD Hub, the FASD month of September. So we're delighted that we have Dr Alex Carlisle with us. Fantastic to be starting September off with this webinar. For anyone who's not joined us before or joined a webinar, we can't see you and we can't hear you, so don't worry about what's going on in your background. We have the chat facility and the question and answers at the bottom of your screen, so please feel free to ask any questions or make any comments through the presentation, and then at the end I'll come back on and I'll ask the questions, but we don't say anybody's name, so everything's kept very confidential. Also, please don't worry about writing lots of notes, because all the slides are going to come out in an email format, because there's lots of information to take on board. So I shall pass straight over to Alex and say thank you very much.
It's really a pleasure to be here. I'm going to crack on with the presentation because there is a lot to do. So I'm going to screen share with you, and please wave at me if it doesn't work. So hopefully I'm going to start the slideshow now. Is this working? Can you see?
Yes, we can see it. Yeah.
Can you see from the beginning?
Yes, that's it. That's, yeah.
Great. Nice. Okay, so yeah, I work at the FASD clinic in Surrey, and I think you're going to see some of my other colleagues and the team lead in another webinar. So I won't talk too much about that because the day is really about positive behavioural support. And I'm taking on the bold task of trying to explain positive behavioural support and FASD in 40 minutes. Some would say that's slightly mad, but anyway, we'll give it a go. And please, as we've already mentioned, don't feel like you have to take everything in and kind of absorb everything from the slides, because there will be a copy of the PDF of the slides coming to you. So I'm going to start with some firm foundations that are kind of helpful no matter what we're talking about, and then talk specifically about positive behavioural support, or PBS, and also FASD, giving a very brief overview of that because I know you're going to be talking about that for the rest of the month, so I won't go into too much detail about general overview of FASD. My kind of main focus will be specifically looking at the positive behavioural support and adaptations for FASD, and also classroom strategies, and then have a bit of a wrap up with some final thoughts, and the resources will be kind of on the end of the slides. So without further ado, let's look at the firm foundations. And really this might be sort of information that people are quite familiar with in the adoption world already. I'm just kind of pointing and signposting to it as a kind of a layer of good practice before we think about other approaches, such as positive behavioural support. And I just sort of spotlighted developmental practice, but there's sort of other kind of therapeutic practices and therapeutic parenting approaches that have just general good kind of advice and helpful approaches for parenting generally. Neurotypical children, non-neurotypical children, and adopted children. So we're thinking about using playfulness, acceptance, curiosity, and that would be like a genuine curiosity rather than, so I'm wondering why you're behaving like this. And then, you know, the empathy is an important part, and showing that you've accepted and understood. So I'll move on to think about a few other things that are helpful with sort of building that firm foundation. And this is, you know, I'm talking to myself as much as anybody here as a parent, modelling the desirable behaviour that we want to see. So that includes self-compassion and kind of being okay with our own mistakes. And I don't know if anybody's heard of the growth mindset. It's been around for a while in educational terms, and sort of seeing our own mistakes and our children's mistakes as opportunities to learn. So we tried this, okay, we know that doesn't work. What else can we try now? And really accepting those as opportunities for learning. So we talked about the kind of firm base, and I'm just going to assume that all those things might be in place. What else might we try for helping support children? And I'm going to start off with a sort of general positive behavioural support overview. And this isn't necessarily specific for FASD to begin with. It's really positive behaviour support is kind of a blend of functional analysis and a person-centred approach, what that means in reality is really changing the environment to sort of help facilitate learning and ultimately enhance a person's quality of life. And I will try and give you a flavour of what that means, although there are kind of lots and lots of different types of positive behavioural interventions. So I'm really kind of boiling down to the nuts and bolts today, what some of the key elements might be of positive behavioural support, but it's a term that might be used quite widely and in a varied way. So if this doesn't necessarily fit with what you know of positive behavioural support, I wouldn't be too surprised, but that it's a very broad area. What PBS is not is use of coercion or punishment, and it's definitely not a sort of one-size-fits-all approach. If you do this, this and this, then you're done. So hopefully that will become clear. But why would I be talking about positive behavioural support today as opposed to anything else? The reason is because this has been shown in the research to have had a beneficial effect in FASD. That's not to say it's the only thing that has a beneficial effect, and it's not to say that there won't be future research that shows sort of some things might be more helpful than others. But at the moment, in terms of the limited research that we have available, and we need far more research into interventions in FASD, especially sort of the long-term outcomes. But what we have available shows a kind of positive outcome using PBS. So that's why I'm presenting it to you. And specifically, interventions are targeted at people's individual unique neurodevelopmental profiles. That's the foundation of it. So an example of what PBS involves is sort of in relation to behaviour that might be affecting an individual's quality of life. You would identify what function a behaviour is serving. In that will be the antecedents, behaviour and consequences. And I'll go into detail about what that means. And it would also involve identifying a functional substitute. So that might be identifying that sort of alternative behaviour and then reinforcing that behaviour. So an antecedent is it's a big word that happens to fit in with the ABC, but what it means is what comes before, or a trigger, or a predisposing factor, or a situational factor. But I'll probably use the word antecedent because it fits in with the ABC. But it really just means what's happened before, and that might be who, what, where was going on beforehand, as well as the individual factors, the predisposing factors, and that could be all kinds of things such as genetic factors, neurodevelopmental factors, adverse postnatal experiences, prenatal alcohol, for example. So all kinds of different things go into the predisposing factors. Then the behaviour itself, how is that actually impacting the quality of life? And what is it communicating? What does that behaviour tell us? And then when we come on to consequences, we're really thinking about, in terms of positive behavioural support, there's really sort of three definite ways in which kind of behaviour can be responded to. One is a neutral outcome, where there's theoretically no reinforcement going on, and we'll talk a little bit about what reinforcement means in a minute. And then another is removal of aversive stimuli, and that's called negative reinforcement. And again, I'll give an example. And another is a positive outcome, also known as positive reinforcement. So there's different ways of the sort of outcomes of the behaviour is the consequences. So this is a fake example that I'm going to give you. I don't think knowingly I've ever worked with anyone called Eddie. And I've never had this specific situation occur, but it's kind of like an amalgam of different situations that I've come across in the clinic. And in this example, Eddie's at school and they're in a geography lesson, and Eddie is talking a little bit, and the teacher starts telling the class what the task is. And he does stop talking, but the teacher then tells the class that they have to get into groups and they have to choose between them a topic, and then they're going to present about this topic to the rest of the class. Now Eddie loves volcanoes, so he's in geography lessons, so that's great. He might think that he could get the rest of the group to talk about volcanoes, but sadly he didn't convince other people, and he didn't have the ability to understand, he didn't have the theory of mind to understand why other people didn't think it was as important as he did. So he was really quite confused and upset about that not going his way. He was also distracted when he was being told the instructions for the task, and didn't quite understand them. And so he'd got a different view of what was supposed to happen than other people. And there was a lot of noise in the class, and because they were getting into groups, they were sitting differently, and he was much closer than normal to the other children. So there's kind of like a perfect storm of things going on for Eddie here. And he starts to fidget. And then when it becomes clear that the group really doesn't want to talk about volcanoes, he starts kicking the chair in front of him. And understandably, the teacher at a certain point thinks that that's not tolerable and sends Eddie to the inclusion room to calm down, thinking that that might be helpful. But that also at the same time negatively reinforces the behaviour of the kicking chair, because actually he was much happier once he was out of the room. He was having such an unfortunate unhappy time in the room and those circumstances, that being out in the kind of quieter environment was much more preferable to him. So that's just an example of negative reinforcement. An alternate kind of situation might have been for the teacher to sort of say specifically, in this case, go and do this task with these group of people. And it might have been an opportunity for the teacher to use his love of volcanoes, as it was a geography lesson. Obviously, this is my imaginary world. I realise that life isn't always that easy, and teachers have curriculum to go through. So this is kind of my imaginary example. The teacher might also be able to give a visual cue of the task and break it down visually ahead of time, having planned what the task would be, so that Eddie can refer back to it, because auditorily he finds it difficult to hang on to the information that he's been given. And also, if there isn't an opportunity for sort of visually putting things down clearly, breaking it down into really simple language and perhaps repeating that might have helped. Also, the sort of sensory triggers might have been removed. So it might have been that the small group could have gone into a different room, and it might have been that there was a possibility to have a sort of quieter area. So also in terms of the behaviour, it's something that people tell me sometimes it's really hard for people to see what leads up to sort of more of a sort of what people often term an emotional outburst, or sort of some act of dysregulation, and that can happen quite quickly in FASD. But in this imaginary example, and sometimes in the clinic as well, there are little signs and little telltale kind of cues on the way up to a sort of an episode of emotional outburst. And in this case, his fidgeting increased. And so at that point, the teacher might have seen that as an opportunity to redirect and maybe sort of instigate a calming activity, such as a brisk walk or long exhale. And then if Eddie was able to then self-regulate and cope with the situation, then the teacher can reinforce that and reward the sort of new non-aggressive coping strategy immediately with a with a desirable reward, so not non-desirable. Okay, and maybe in this case it could be a volcano sticker. So that's really a sort of fake example of how the different types of reinforcement might happen. Essentially, in the brain, what's going on in these examples is the strengthening and weakening of signals in each sort of occasion of learning opportunity, and the synapse of the junctions of the brain is becoming stronger or weaker, and some of those connections are being formed and some of them are being lost. And essentially what we want to do for less desirable behaviour, or behaviour that's affecting quality of life, is we want to kind of really weaken those signals by reducing antecedents. That helps weaken the signals, or Norman Deutsch refers to it as neurons that fire apart, wire apart. It's actually not that easy to say that. And a kind of pictorial way I like to think about it is if you have a field like this picture, and you're essentially trying to go from a track, a dirt track, that's sort of relatively well trodden, and people might cross the field every day, and so it gets quite muddy and the grass doesn't grow. And really you're trying to sort of essentially kind of fence off that area so people don't walk over it, and you want the grass to grow back. In terms of reducing antecedents, you're trying to just kind of disestablish the connections between certain synapses, certain habits. You're trying to weaken that relationship between a certain stimulus. In this case, it was the kind of all those antecedents that we mentioned in the geography case, the sound and the ambiguity of the task and not understanding what people think, reducing the kind of connection between that and the outburst of the behaviour that was sort of impacting Eddie's quality of life. Then you've got the sort of opposite of that, which is really strengthening the signals for desired behaviour. So whenever something does happen that is sort of enhancing the person's quality of life, enhancing their social skills, enhancing their sort of adaptive abilities, you're really wanting to kind of reinforce that and reward that, and that will strengthen the circuit. Neurons that fire together wire together. It's a bit easier to say. And in terms of the pictorial image for that, you're really trying to encourage the traffic flow. So rather than just a dirt track, you're really wanting it to become like a motorway, so that those neurons kind of are really well connected, and that it just happens automatically by habit, that when this stimulus happens, this response happens. In sort of summary then, we've got reducing antecedents, things that might trigger problematic behaviour or behaviour that affects the person's quality of life. You're trying to reduce those as much as possible to weaken the circuits. You're trying to reward the desirable behaviour as much as possible with immediate valued consequences, and everything else in between you're just trying to sort of ignore, and kind of is sometimes referred to as annoying but tolerable behaviours. And you know, every person alive, we all have annoying but tolerable behaviours, and essentially it's having that neutral response for those. And then for those behaviours that might cause harm, for example, you want the clear boundaries and that kind of consistent, clear message, and as much as possible removing any accidental reinforcement for that. And I've got a picture of a donkey here because an example of how kind of it's important to really reinforce the positive and desired behaviour is it when the donkeys used to kind of work in the mill, they went round in a circle. But when the mill was closed, they went to the seaside, for example, to work there. And the people who were sort of now in charge of them wanted them to walk up and down, give the children rides, but they didn't know how to walk in a straight line. And so rather than hitting the donkeys on the back with a stick, because that didn't help them know how to walk in a straight line, the owners gave them a little bite of a carrot so they could be motivated by the carrot, take a step, take another little step and another little bite, and eventually with enough carrots the donkey was walking in a straight line, and ultimately those circuits were strengthened for walking in a straight line and the carrot wasn't needed. Oops, just going back there. So just to summarize, the stick approach doesn't teach what we want to see. It might give you a signal that that isn't the right thing, but it doesn't tell you what the right thing to do is. So that's why rewards and things that are inherently motivating, which by the way might be very different for different people. And while I remember it, I'll just say in FASD, sometimes children don't respond to rewards in the same way. So that might be very bespoke and very different for different children. So what is fetal alcohol spectrum disorder? I've given you quite an in-depth brief overview of PBS. Now I'm going to give you a brief, hopefully, overview of fetal alcohol spectrum disorder. So essentially it's what happens when individuals are exposed to alcohol in utero. But because there are so many variables like dose and timing differences, genetics and environmental influences, there isn't really a single pattern of sort of neurodevelopmental problems or difficulties, and there's no sort of one single measure that we can use either. So really, it's really important to bear that in mind with the information that I present next, because every child really is very different, and I'm presenting a kind of most common picture, but that doesn't mean that would be true of your children or potential adoptive children. It's a general overview that I'm presenting, and that's why assessment is really helpful to get an individual's chart sort of profile, because it really is variable. In terms of criteria for fetal alcohol assessment, which I won't go into detail about, but what we look at is these 10 domains, not necessarily all of them in our clinic, but they need at least 3 to get to diagnosis, and quite often there's information from sort of other sources that would indicate there are sort of more than 3 areas of difficulty. So there's quite a lot of, as you can see, domains that we look at, and I won't go through them now. I would encourage you to look at this link. It's a wonderful pamphlet, and there's also another one that I think my Scottish colleagues designed, Making Sense of FASD, which you might learn about in another webinar, but that's also excellent. And this one and the Making Sense of FASD is really helpful in terms of easily accessible information, good examples of what is FASD. And this picture is nice because it gives you an idea of how different the different skills and areas might present at. So you've got somebody with a physical age of 18, and they've got here a reading sort of age of 16, but a social skills age of 7. That's not to say that everybody with FASD has that profile, but that's just an example of how varied it can be and how confusing that might be for people supporting the child and the individual themselves. Again, this is just a sort of really brief flick through some common problems. I'm not expecting you to read all these, but they are kind of my summary of common, my sort of anecdotal clinical view of the common difficulties that we see from having written many reports now. These occur a lot. That's not to say that if your child doesn't have these, then it's not FASD, or if they do have them, then it is FASD, because obviously we need to rule other things out, but these are really common in FASD. Also, I hear in the clinic a lot, really commonly, these sort of situational antecedents, particularly the word unsupported environment is often a trigger of behaviour that's going to cause a problem. And there is a big difference between sort of adult-led activities versus activities where the child is having to sort of really apply long-term rule maintenance on their own and be in an environment of unpredictability in social situations perhaps, or in sensorily stimulating situations. So we come on to positive behavioural support and FASD and specific adaptations. How might brain differences in FASD affect how we apply the positive behavioural support that I kind of described earlier? And I'm going to really pick out 3 examples of difference. They're not exhaustive, and they're just, again, based on my sort of clinical feel of the things that come up. But there are more, and there are sort of nuances and subtleties that are different from what I'm presenting, but just to give you a flavour. So the first one is blood oxygen level dependency. Some research that I think is really helpful to be aware of is that it showed between individuals who were prenatally alcohol exposed and those who weren't, they did a spatial working memory task. It doesn't really matter what that task is, but it wasn't significantly different between the 2 groups. I think the prenatally alcohol exposed group did had slightly different reaction times, but not significantly enough to sort of show up. But then when you looked at the blood oxygen level dependency, which is in terms of how much oxygen the brain's using, there was a significant difference, indicating a greater information processing effort for the prenatally alcohol exposed group. So you've got children doing a task or individuals doing a task. They don't have any observable difference really significantly on the task itself, but their brains are working very differently, and there's a lot more effort going in. So that, I think, is really interesting and helpful to know, this hidden effort. Secondly, we have something that happens with children with FASD that is called hot executive functioning. Now, we all might get sort of less effective when we're emotionally aroused or upset in terms of our executive functioning, but really when you add emotional arousal with the FASD group, you see a significant difference in functioning. So executive functioning are really a set of skills, very broad again, that are to do with goal planning, goal-oriented behaviour, including things like inhibition, problem solving, managing complex information, cognitive switching. Almost any task involving sort of completing a goal involves executive functioning. It's something that we use a lot. And sometimes children with FASD have difficulties with cool executive functioning, that is on task where there's not a great emotional load. But when we add that emotional load, there's some research that shows that there really is a very significant difference between the children with FASD and those without, especially in terms of decision making and risk taking, and that inability or difficulty to learn from negative experiences when there's that additional emotional arousal. In this task, in this research, it was a gambling task, so that was kind of an exciting stimulus and the stakes were high, or the people involved thought the stakes were high. They all ended up with the same reward and outcome, but at the time of the assessment they didn't know that that was going to happen, and that really affected their decision making. And so the sort of third area that I'm going to present of difference in FASD, this is a potentially overwhelming slide, and thanks to Ed Riley for permission, well, vicariously via Raj, to use this information. But essentially, if you look at column 1, that's FASD, and column 2 is controls, and you can see the column difference between columns 1 and 2. That's in response to a conditioned stimulus. And then in column 3, you have FASD, and in column 4, you have controls, and that's showing a different response to the unconditioned stimulus. And I'll quickly move on from that overwhelming slide to really kind of summarize in my own words what that might mean. Essentially, there's an enhanced activation to an unconditioned stimulus, which an example of an unconditioned stimulus is, for example, food, which is naturally, certainly for me, naturally sort of stimulating, and you don't need to teach that response, you get an automatic brain response. In the FASD group, you had an automatic response that was much larger. You also saw in these results the lack of prediction between the conditioned and unconditioned stimulus relationship for FASD. Essentially, that means it's just a more random response to stimuli, and you don't get that progressive learning. And when you look at the sort of parts of the brain, it was sort of real lack of engagement of the frontal and parietal parts of the cortex. And so the way in which the brain is processing information is not happening in the same way between FASD and control groups. Now, again, this is just research, and it's just one example, and not everybody who has FASD has a brain response like this. It's just in general terms, we can see that there are differences. So what do all those sort of different bits of research tell us? And how does that map onto what I see in the clinic as well? Essentially, hidden extra brain activity from the BOLD research, blood oxygen level dependency. So what do we do about that in terms of accommodations? We can recognise that everything's going to take more effort, or certain tasks, and in this case it was a spatial working memory task, which is a common problem for FASD, things like maps and visual sort of spatial planning and processing. And we can just also recognise that extra effort and give more breaks. Secondly, emotional arousal really decreases the ability to learn from negative experiences. So that was the hot executive functioning example. So what can we do? We can reduce situations where the children are put in that sort of extra high stakes environment, which would be an external kind of support in terms of trying to reduce the arousal as much as possible. We can also teach kind of self-regulation strategies, which would be like an internal, something that children could do themselves. But I would just quickly add that it wouldn't be assumed that children should automatically, be taught this self-regulation strategy, and therefore you don't need any external support. It's about doing both at the same time and providing that external support, as well as over time building up those sort of self-regulation skills, and so really only letting go of the external when it's really solidly learnt in terms of the internal reliability, if you like, of awareness of danger and ability to learn from experiences. Then thirdly, looking at the brain differences, as I've sort of already alluded to earlier, sometimes the brain of people with FASD might not respond in the same way that you maybe expect, and some children perhaps might not like rewards, some children may love rewards, or it just might not be a sort of response that you'd expect, and it might not be the route that you'd expect in terms of the way that the brain is actually kind of physically processing that information, and so it might need extra time to allow the learning to take place. It might need repeated opportunities to allow the learning to take place, simplification to allow it to take place more smoothly, and then again that continued external prompt. In summary, I don't know whether people have heard of the zone of proximal development. It's quite a widely known thing in education, certainly, but really we're looking at, in terms of sort of managing antecedents, you're looking at starting from that zone of proximal development. Where should I start? Sometimes it can seem overwhelming, but we're looking at reinforcing desirable behaviour where the child is already kind of able to function well with support. And when reducing antecedents, we're really looking in the areas of attention, emotional regulation, executive function, communication, social and sensory difficulties. Sorry to whiz through, just can see the clock ticking by. So this is a really nice kind of visual, and I won't go through it in detail, but what I really like about it is it looks at the behavioural symptoms, and then it looks at the kind of accommodations that you might need to make for children or individuals in relation to those behavioural symptoms. And it also looks at the brain differences that might underlie that. They're not exhaustive, but they're a good example. And it also looks at the sort of second column, can look like. It looks at kind of how people might perceive, if they didn't know that it was FASD or there are other difficulties going on, how they might sort of negatively misattribute what was happening for the child. So this is a really helpful table by Adrienne Ella-Lechista. In terms of classroom strategies, I'm going to whiz through these again because I'm running out of time, but you will have all of these on the slides. And I've based these on this lovely resource found here at this link, as well as a little bit of my clinical experience. So it's just kind of a mishmash. Really, a lot can be said for the effect and the impact of shifting attitudes and improving understanding around the child, in terms of perhaps just helping people not misattribute what's happening, and that the child is really trying hard. There's all that hidden effort going on. That doesn't mean that if only they could attend more and they could try harder, then maybe they could attend. The inattention is not because of lack of trying. That kind of understanding, and sometimes it doesn't take much to get that message across. Recognizing that the child is trying hard is a good start. Then, as I've mentioned, sort of not misattributing behavior, but also translating behavior as a useful thing. So sort of seeing that fidgety child might be communicating something helpful, that they need a break, for example, and really thinking about that function of that behavior that we talked about earlier. A consistent classroom environment. I mean, a consistent environment would be a good slide title as well, but sometimes children actually seem more settled in school environments because it's more possible to have that consistency, and it's difficult at home because generally home isn't a place for completely strict structured routines, but sometimes people come to the clinic who, you know, are so impressive, the way that they are kind of strictly running by routine, and everybody in the house knows exactly what's happening when. And, you know, different family setups will have different things that work for them. So in the classroom environment, as much routine and structure as possible, minimizing transitions could be really helpful. And that's the last one on the second column, providing tasks that involve regular movement. That's often one that I hear. Social skills support, I've got some references at the end for ideas for those kind of programs or approaches. Essentially, it's about not letting that kind of safety net go. At the same time as teaching the social skills, it wouldn't be assuming that just because a child knows in one situation, this is how I say hello and this is how I manage this particular person, that they can then apply that always and at all times. So it's really about having that safety net as well as continually teaching those skills. In terms of accommodations, really helping sort of, if possible, helping people understand that because of the difficulties, the child doesn't need just extra sort of opportunities to continue to always maybe learn how to write things faster. If the child has a fine motor skills difficulty, that's going to, you know, be really, really hard. So it's about finding that balance between developing the skill of the handwriting, for example, and allowing the child to really access the curriculum, maybe with an accommodation such as a tablet or a computer. I think different schools have different approaches to that, so that might be something that needs negotiating. But generally there are other things that can be done as well, and I like the idea of fixing frequently used materials onto the desktop, for example, or somewhere in the classroom that's easily accessible and not too visually overwhelming, that the child can refer back to. That might make a big difference in the way that a child understands a certain subject. This is a really important one, specific language, really clear prompts to task, and often children really don't understand idioms or metaphors or sarcasm, and we use so much of it without even knowing. So usually most parents, by the time they come to clinic, really are very proficient at just keeping things very simple, using 1 or 2 keywords, and knowing what the child will understand, which can really help a lot of behaviours and help a lot of children feel very regulated and calm. And often it's a sense of overwhelming kind of language load, which, if anyone was listening to this, but this is how it feels. I'm sure, yeah, the child feels very overwhelmed very quickly by more than 2 or 3 key points per sentence. Again, it's different for different children, but that's something that really commonly comes up. And then physically sort of making the environment as less sort of arousing as possible, reducing the amount of information, reducing the amount of stimulation. Again, this is a generalization, but that, you know, in terms of noise and visual stimuli that can be distracting, that's a common one. Math support, there's a lovely program called the MILE program, and I mention it because it kind of really focuses on the core deficits of math difficulties, but it's also really good generally for thinking, kind of giving people and perhaps pointing teachers in the direction of things that might work well for children with FASD and approaches that work well. Just a little 10-minute video on it, so that might be good to kind of follow up and look through. So in terms of my final thoughts and resources, so going back to the beginning, it's about antecedents and reducing those, making accommodations for any triggers wherever possible. Rewarding desired behaviour, thinking about that donkey needing to know what to do, what the right thing to do is kind of giving a clear message of that, and sort of with immediate and valued rewards, with that extra just awareness of sometimes children have different reactions to certain stimuli, so sometimes certain rewards might not be a good idea for some children, might be over arousing, for example. So about finding the right reward in the right moment to do that. Setting realistic goals for yourself. If you are going to approach some positive behaviour support work, really have very small achievable steps, really start in that zone of proximal development, where is a child able to kind of, what's a child able to do with support. so that you're able to be consistent. It needs to be small, because otherwise it will become very difficult to continually apply something, especially sometimes when you get an extinction burst with a certain behaviour. So start what you can continue. And last but not least of this little summary, be really kind to yourself. And your well-being, as I'm sure you know, you talk about this, I expect, in this forum, your well-being is so important for your children. If you kind of forget most things, just remember that. Difficulties appear hidden. We've talked about how the brain is different, and you can't necessarily see that. The brain waves are acting, not the brain waves, but the brain patterns are responding differently, and the blood oxygen level is kind of different, and people can't see that. But you can see the sort of outcome. You can see the fatigue, you can see the upset, you can see the hyperactivity, which is often what happens when there's a lot of fatigue. Obviously, for hyperactivity and emotional dysregulation can happen for other reasons as well, but it often is a sort of overwhelm of just too much stimulation, too much effort having gone into something. And children with FASD often are very verbally fluent, but that doesn't mean that they're necessarily understood, which can be a real misdirect. So children come to the clinic and they really are wonderful and fascinating, and I have a great time talking to them, and they'll be nodding away. But if I asked what I just said, they wouldn't actually be able to necessarily sort of say it back to me. But if I hadn't known to ask to check back, then I think it would have been easy for me to assume, and for other people to assume, that the child fully understood. Change might be gradual. This is a Temple Grandin quote, who has autism. There was no single breakthrough. And I would also just add to this, change could be immediate. So we never know, but it could be a long series of incremental steps, but some changes can happen developmentally. The brain is amazingly plastic, and you never know. I would really recommend Carolyn Blackburn. I've spoken with her at some conferences. She's done some amazing stuff on FASD, and some of these other sort of sources have really rich information, and I've only given you literally the tip of the iceberg. There's so much free information available, and these are some useful websites as well. Some of them are sort of for things that aren't necessarily free, but you can read about them and find a lot of information out about them free. And this is some useful books as well, but I'm just aware that I've gone way over time, so I think that's the end there. I'm gonna stop screen sharing now. Thank you for not hoisting me off, even though I've gone over time.
No, thank you so much. It was fascinating, and such a timely reminder with everyone, you know, a lot of our children going back to school at the moment, with those hints and tips for school, because I think we've all kind of can get so caught up with what's going on that to take it back to basics and remind us was fantastic. So thank you so much. Fascinating, and this is, you know, I love learning all the time about FASD, so thank you very much. So we shall hand over to the members and see if we've got any questions. But I said lots of information to take in, but don't worry, because the slides will be coming out, and so you can go back, and also if you want to watch this again, please feel free. So if you want to pop anything in question and answers, if you've got anything for Alex. It'd be very unusual to have no questions whatsoever. So it could be that you've stunned everybody.
I know, it's a bit like a fireman's hose of information, isn't it?
Yeah, yeah.
Just like,
I've had a comment come in here, really interesting. Thank you very much. So thank you for posting that. And I think it was great having the two sides to your presentation today, with about the positive reinforcement that we can all be doing. Another one here, what would Alex suggest is the best way to encourage educators in positive behaviour?
that's a really good question. I guess a conversation with the teacher. I presume you mean sort of teachers and schools. A conversation with the teacher helps, and I'm never cease to be amazed by how much parents and carers have really got their children. They, you know, by the time they come to clinic, certainly they've known the child a while. And, you know, they know all those little telltale signs that the child is exhibiting, usually those little facial expressions, or those sort of scratches, and those things are so important to really communicate with the teacher. So teachers might know about positive behaviour support, and I presented to some teachers a little while ago, and, you know, they really did know most of it already. They were just like, oh yeah, we know all that. It was just that once they kind of got their head around, oh, so the child needs support, and that, you know, that it's not because they're not trying. Oh, it's like attention is their biggest problem, and executive functioning, so we need to break things down, give them visuals. They had, you know, they were totally on top of that. And, you know, some of the resources that I've given might be really helpful for some teachers, and some teachers at schools might know all that already. It's just really a question of identifying that those, you know, making sure that those difficulties haven't been misattributed to other sort of adverse experiences that a child, that sort of people don't think that actually putting in place structure and visuals and repetition and simple language, that is really helpful. And rather than just thinking, oh, it's their life experience to date, therefore, you know, they need therapy, which I'm not saying they don't, but that, you know, you can't ignore the neurodevelopmental stuff. So it's really having that conversation and saying, yes, this child does have this history, but also there are these other things that might be going on. And if you haven't had an assessment yet, you know, can we just try some of these things and see what happens? Does that help? That could be really useful information for an assessment. And lots of times that has happened by the time a child comes to an assessment, and schools are putting some really good things in place.
Right. We've got lots of comments, lots and lots of questions coming in, so we're going to try and group them together because there's lots of questions. Can people share your slides with their schools?
Yes. Yeah.
Because I think that may be a way of opening up a conversation.
Yeah.
You know, explain it's FASD month. Here's a presentation that I took part in. Thought it might be useful to you. Yeah. So we've got some questions here. What recommendations do you have for someone who's just realised that their child is likely to have FASD? And I remember that moment, that light bulb moment I had, and I sat in a training and I was just nodding along to everything that was being said, thinking, this sums up my son.
Wow. Yeah, I can't, yeah, it must be quite, on the one hand, like kind of, oh, that might explain it, and on the other hand, a bit scary, I would imagine. And yeah, I would say take it bit by bit, and not just necessarily assume, because it would need to be a question of having an assessment and ruling some other things out, because there are some genetic syndromes that could potentially be similar, and it depends obviously on the prenatal alcohol history. But assuming that it might be FASD, I would say, yeah, read those Making Sense of FASD booklets, and the sign guidance is the first thing I would do. Get a bit more of a sort of flavour for whether or not this could be something that might fit. Yeah, and I would say that there's some wonderful support networks as well, and I would, you know, make use of those. I think you don't have to necessarily have a diagnosis of FASD to make use of those, do you? So I would say, yeah, definitely make use of those. They're excellent. And just going back to the previous question about school, and I think I saw a comment, you know, some schools really struggle even when they've had the training. Yeah, I would recommend people getting additional training. As a clinic, we don't really do much training for schools. This was sort of a one-off thing that I did, but there are some organisations, and I don't want to specifically highlight one, but there, you know, some really fabulous people who go around doing some lovely training. So I don't know what kind of training in this example was not necessarily gonna hit all the buttons, but I think I've had some feedback from, you know, that there are some really helpful ones. And
often, isn't it, it's the drip approach that, you know, keep feeding information into school every opportunity you have, because at some point often the penny does drop and they do suddenly go, oh right, okay, that makes sense.
Yeah, I have quite a few parents who experience their child is sort of essentially managing in school because they really want to do well. They're so, you know, really care, and they really don't want to be emotionally dysregulated in front of their peers, but they are still emotionally dysregulated, but they're just holding on to it. And so the school doesn't really see it. And so that can be really difficult when schools don't necessarily see it at school. I can see how particularly those conversations are quite tricky to sort of get around. Well, is it something that's happening at home then, might be sort of the approach from the school. But if you can just go into that situation knowing that's a common response, and then like, actually no, it's because, you know, here's the research that shows that the brain is working harder, and that's why, you know, they're still able to kind of manage their emotional arousal just about at school, although things quite often leak out. But definitely when they're in the safe place at home, they can't manage that anymore.
Yeah. We've got some questions linked around having a child diagnosed, and is it worth, in this case, a 14-year-old being diagnosed? And I think everyone that we've spoken to, adults included, have said it really helps at whatever age.
Yeah, I mean, I might be biased, but the feedback I get is usually it's a really helpful process for people, that they, you know, they know something's not quite right. They're continually getting feedback. Can you stop doing that? Stop fidgeting. Stop, put that down. You know, why don't you listen to me? They're continually having that experience of life, and sadly, sometimes people internalize that, and that causes sort of secondary difficulties. So that's why to have potentially a diagnosis, even if you weren't putting in place other things to sort of help that we've talked about in the antecedents, if just to explain, you know, oh, it's not me, you know, I'm trying my best here. I can you know, I can see that this is something that's just different with my brain. So I would say yes,
it's worth doing.
It's worth it.
Okay, we've got some questions which are coming up around FASD and where autism and ADHD may sit underneath there, or whether there's crossovers to them.
That's a great question. So if I was to go back to that sort of slide with all the 10 domains on it, one of the domains is social communication, and within that sits autism. So one of the domains of the sort of diagnostic criteria essentially is autism. So yes, it's very much a part of a potential outcome is autism, or even if children don't meet criteria, sort of threshold criteria for autism, they might have social communication difficulties. Then in terms of ADHD, there's two domains that covers. There's the inattention domain, and then there's the executive function domain, which includes impulsivity and hyperactivity. So if you've got the inattention and you've got the hyperactivity and impulsivity, then you have ADHD. Or if you just have the inattention on its own, you have ADHD inattentive type if they meet threshold criteria. So it's very common presentation in the clinic would be ADHD inattentive type and social communication difficulties that may or may not meet criteria for autism, as well as executive function difficulties, but not necessarily hyperactivity, sometimes hyperactivity, depending on the age of the child, because again, that is something that we often find that with age, the hyperactivity might reduce somewhat.
Yeah. Sorry, I've got quite a few more questions, and I apologise to everyone. We're trying to group as many together, so we won't be able to answer everybody's, because there is literally so many questions coming in.
Please feel free to follow up as well if you don't think I answered that.
So there's questions really around school, and especially transitions and free time. And I know from experience that can be the hardest part of school.
The transitions and the free time in school, yeah. A lot of children I've seen recently have sort of some kind of supervision arrangement where they have a lunchtime supervisor, or, you know, and that's really seems to be working well for both parties, or they know that they go to a particular area of the school that is sort of lightly supervised by a particular person. This is more primary age. It does get more difficult obviously in secondary school, and it gets more difficult if the school is not able to provide funding, or the sort of extra funding that they have available in their kind of pot isn't able to cover something. So in terms of solutions that don't involve money, I would say have a plan in place for where the child knows that they can go to be safe and quiet and calm, And although we might feel like it's the best thing to do to always be playing with somebody in a playground, that might not be the most wonderfully sort of that might be over arousing for certain children. I mean, it might, for certain children, they might love it, but it's just about being aware that what our sort of expectations of a good playtime is not necessarily the same for all our children. They might actually just need that time. They might be so tired from trying in class that they just need to sit down, or they just need to run around and not have any sort of social interaction, and actually trying to sort of engineer playing with other children where they're learning social skills that potentially could be good, but without sort of supervised adult support, that might create more problems and more over arousal. So I would say ultimately the best thing would be sort of having somebody supervising contact, but that obviously isn't always possible. And so having a kind of a plan in place for where a child can go that they know is a safe area or a quiet area.
And often that's where the reception staff, especially in primary school, can really come into their own. Sometimes having a shorter lunch break and then having some key jobs to do in the school can work really well.
There's some amazing examples. I mean, some children have got these plans and these schedules of kind of, you know, physical activity movement breaks during, you know, they have a schedule, this is what I do first, and then I, you know, and it's all planned out. Or like you said, that they've got, you know, they go and do the register, or they have a particular responsibility, and that enables them to sort of, or they have, you know, for older children, they have accommodations in the library, or maybe other children aren't allowed that, but they are. And then quite sort of secondary schools, I think, you know, have a broad range of children with range of difficulties. There are potentially options, but it's finding what suits the child, because the child might not by that age want to do that, or there might be other children around who, you know, aren't great for that person to hang out with.
And you can really tap into their interests and get the school to tap into their interest.
Absolutely, that's a fantastic point. Yeah, there usually is something. Don't know that I've ever seen anyone where there isn't. So there is usually, I mean, I know we're a sort of unusual clinic in the sense that we see potentially more severe end of the spectrum, but yeah, that's a really good point. Yeah.
Thank you. Do you have any top tips for transitions from school to home and home to school?
I'm just going to say again what I've heard has worked for other people. So one idea that I've heard recently that I thought was really good is that, and again, it might be different for the particular issue for that child, why it's so difficult, but for one child, it was the extra noise in the classroom and the having to plan and pack it at the same time as all the hustle and bustle around. So what had been organised was that the child was picked up later. Now, for some children, that might be horrific, that might be really upsetting, but for that child, it's sorted out the problem straight away or soon enough, because they were able to just go at their own pace, and then by the time everybody else had left, the teacher then could help them pack up and do that last little bit, and they felt a bit more special. That might not always be possible, I do understand that, but there might be sort of some other areas sort of that can help, like the visuals, having a list of what things you need to actually do to sort of go from one thing to another, especially sort of home time. That involves usually kind of collecting things from various areas, and that involves a lot of executive function skills. So generally I would say trying to help the school understand that if the child can't do it, they're not being difficult. You know, you might need to go in as a parent at the end of the day and help them if the teacher's not able to support that.
Yeah, thank you. Sorry, we've just got a few more if you're okay.
Sure. Yeah.
There's quite a few questions around people actually getting a diagnosis. So how can they get referred? Who can they go to? Do they need to have lots of evidence? And there's also, I think, a bit of concern that's coming through that their child is very good at masking. And I would say that you absolutely see through all of this, so don't worry about that. Anything that I thought was like, well, they're never going to see, he doesn't normally behave like this, you were spot on with the money and saw straight through, so don't worry about the masking side.
Yeah, no, we're very well aware that, you know, essentially we're almost kind of an ideal condition because it's one-to-one sort of adult attention, and you know, the day is all about them, and they can, you know, I'm particularly interested in that first bit of the session and just seeing what the child will do with sort of without structure sometimes. And you know, sometimes that's just a wonderful thing, and sometimes, especially for younger children, they do get a bit fizzy and hyperactive, so that's interesting. But you might not see, we're very well aware that you might not see in the clinic directly the difficulties, but we do see the difficulties because of the different things that we do during the day. So there's always opportunity because it's a long day as well. So by the end of the day, it will usually be very apparent. And also that's internationally something that happens, and is very well known as well, that my colleagues in Norway, you know, they actually have 2 days, and they say definitely by the end of the second day, you know, I can only imagine how they get through the end of the second day with all the fatigue, you know. Yeah. So yeah, we always see, don't worry about that. But in terms of accessing the clinic, essentially at the moment you still need a funding agreement, so it needs to be an independent, I think it's an IFR it's called, so the local commissioner needs to approve the funding, or there's a sort of private funding option, but that doesn't mean we're a private clinic, we're an NHS clinic, but people can, if they don't manage to secure funding through an IFR, which will be through the sort of, I think for example, a GP who refers would need to seek that funding out, or perhaps the social workers might be able to help if they're involved with that. So it's not a very straightforward answer really of how to get to the clinic, because I think people do have to work quite hard to secure that funding, and unfortunately that's how it is at the moment, but I'm really hoping in future that it will be different.
And start with your GP in England, especially start with your GP as your starting point. Scotland's different. Do you know much about the Scottish system? Because they don't have a 1 day.
I don't, I'm afraid I don't.
And can I get you to come in at this point and just talk about how it's done in Scotland, because it's an ideal opportunity?
Yeah, sure. So in Scotland, we would always recommend people, as you said, Claire, to go through your GP, but there is a pathway where it could come a referral from somebody, say like a head of school, and usually that would need to go to the paediatrician as a first instance, and they're sort of the person that would then hold everything together and make referrals on to speech and language, in particular occupational therapy, and then through to clinical psychology, and they would then bring all of that back together to be able to make the diagnosis. So it's more of a kind of neurodevelopmental pathway, but that is very much depending where you live, as it would in England really, as to how you know, how much that neurodevelopmental pathway is currently under construction, and also the expertise of you know, the colleagues, the clinical colleagues in that area. I guess what we would always encourage people to do in Scotland is to get in touch with us to help parents, and then for clinical colleagues they can go directly to the Foetal Alcohol Advisory and Support Team, who can offer direct clinical support with diagnosis. So that's not for parents and carers, that is for you know, medical colleagues.
Yeah, thank you very much. Thanks, Ali, for explaining the difference with the Scottish system. So thank you. I've got a question coming. Do you know, Alex, the number or the percentage of adopted children that have FASD?
It depends on the research. I haven't off the top of my head got the exact figures, but it's high. So yeah, depending on which particular research, I've got some slides on it that you know, one of them I think is around a third, but then one study I think that one of our colleagues did was a case review was more like 3/4, so yeah, high.
Yeah, it's they, you know, as Ali said here, they're looking at about between 35 and 75%. On a sliding scale. And a question came up about education for children and mainstream, and I'm just going to say my son was a fairly late diagnosis. He was about 12 when we managed to get to the Surrey clinic. He's just finished mainstream education, year 11, and has passed all of his GCSEs. and he's going on to level 2 college. So, you know, I'm absolutely delighted and taking this moment to be a very proud mum, so apologies. But I think it's nice to be able to say that, you know, he was diagnosed late, we've managed to put strategies in, and just how well he's done.
Oh, that is such good news.
Yeah, really, really pleased. So so yes, so thank you all so much for all the questions. Apologies if we didn't get to answer your question directly, but there were so many questions that came in. Lots of comments in the chat about how fantastic it's been, Alex, and really reassuring, and you know, a great starting point for people to then be able to go off and look into. And we just need to clone you and have you everywhere. Because there's just not enough yet. More thank yous coming in for this. Thank you so much for so interesting and enlightening and reassuring. So thank you very much. Thank you again for everyone who's joined us, for being so interactive and asking so many questions. As always, you are fantastic with the questions that you're asking and the topics that we get talking about. We will make sure that this is uploaded by Friday and it goes out on social media, and it'll be available on the FASD Hub Scotland as well as the Adoption UK websites. And the slides will be out as well. So I would like to say thank you so much, Alex, for your time. It has been a brilliant start to FASD month, September, for us, and we are very grateful for all of your support.
Thank you. It's been a real pleasure. Thanks.
Thank you.